Still talking about the urinary system, guys. We will utilize AP obliques only. We're not going to do REOs or LEOs, only LPOs and RPOs. Now, please make note that these are 30-degree obliques, not 45. Because if we do 45, we're actually going to over-rotate the kidneys and not see them correctly. Now, please put a giant star by this. If you're not going to write anything else down today, make sure you write this down. Because this right here is the most missed question of this semester. At least in the past, it has always been, of how the kidneys are oriented to the IR, depending on the oblique. So, the kidney closest to the IR will be considered perpendicular to the plane of the IR. So if I'm doing RPO, the right kidney is perpendicular to the IR. If I do an LPO, the left kidney is perpendicular to the IR. Whatever kidney is perpendicular, the opposite kidney is parallel. So, the kidney farthest from the IR will be placed parallel with the IR. So, you can see how they can really trip you up with that question, because you can actually ask like 4 questions out of that statement right there. There's 2 statements. So, let's say, I give you a question that says, I'm an LPO. The kidney on the left side is what to the IR? You would tell me perpendicular. The kidney on the right, it's on the upside, is parallel. If I'm doing RPO, the kidney that's down is perpendicular. The left kidney is parallel. Please know the difference between those, how to label those accordingly, because you will get questions on that. Yes?
Can you explain the concept of it like being parallel? Like, what is that?
It's the orientation of the kidney. So when I'm putting the kidney perpendicular, let's have a picture.
Yeah, because I was going to ask how do they sit in the body? Because I know they're like kind of like V-shaped.
So when we're saying it's perpendicular, so it's completely on its side like this. This is an RPO we're looking at right here. When I say it's parallel, this will be more sideways.
Okay.
Which kind of sounds like it would be the opposite of that, but the way that they're orienting it, when my kidney's on its side in profile, is what we see right here, it's considered perpendicular. When it's basically sideways, which you can't really see because the pelvis still looks like it's in profile, but the kidney's oriented more sideways right here, like you're looking straight at it, that's going to be considered parallel. That makes sense?
No.
No. We'll come back to it.
Makes sense.
Oh, okay. Can you say that again?
Okay, so when we're doing our RPOs and LPOs, we only do RPOs and LPOs. My kidney that's on the down side, so if I'm doing RPO, my right side's down, that kidney will be perpendicular to the plane of the IR. It'll also be placed in profile. That's the star of our show, the right kidney. The opposite kidney, which is not the current star of the show, will be placed farther from the IR and be considered parallel. Parallel.
So when the kidney is closer, we're looking at that kidney, or the
Yes, we're looking at the downside kidney.
Okay.
That's going to change with the ureters, by the way. So just hang on. We're talking about kidneys here. Kidneys. So the star of my show is the downside kidney on these. Downside kidney. So I'm seeing profile. So once again, we're doing a 30-degree oblique. Don't forget that fact as well, because people always want to select 45. And yes, your answer choices will say 45 and 30. Make sure you choose 30 for these. As far as where we center, guys, a little bit different than what we're used to on obliques in this area, because people think about L-spine obliques. L-spine obliques we center above the crest. But for the urinary system obliques, we're going to center at the crest for our obliques. So we're still going to be perpendicular and centered at the level of the iliac crest. We do center towards the elevated side because it's an oblique. Anytime you do an oblique, you center towards the elevated side. We're still using the 14x17 cassette. Please make sure you remember you're sticking that at the crest, because if we think like an L spine, that can confuse us. L spines, you go above the crest. Urinary, you go at the crest, directly at the crest. My stomach's growling.
I heard it too.
Oof. There it goes again.
You didn't eat it?
I did.
Salad.
Inflation.
I'm hungry.
Salad.
Yeah, my can of peas. It just didn't stretch far enough.
Would you like a candy?
I'm good. I'm good.
Peach cobbler from upstairs. Feel free.
Peach cobbler, that does sound good. With a scoop of ice cream, that would not sit well in my stomach. That sure sounds good. All right, what are we looking at, guys? We're looking at the kidneys, ureters, and bladder, filled with contrast medium. Once again, elevated kidney, parallel, downside kidney, perpendicular. Our main star of our show is that downside kidney. That's the one that's labeled here for you, being placed in profile. By the way, can you see that that is an RPO? How do you know it's an RPO?
Right side
The dotted Scotty dogs, yeah, they're
Sky dogs, the nose is pointing to the right, the eye is pointing to the right. Also look at the ala of the pelvis in comparison to the ala over here. Here's our upside, here's our downside.
What is that? Square around.
That's that compression device.
Oh, okay.
See, I get confused when you say elevated kidney. Like if you're doing a RPO,
That sounds really
left
weird.
side- the left side is up.
That sounds like I told
If you're doing
So
RPO,
how's
left
it-
side's up.
Yeah, so how's it the elevated?
Because the side's
Oh, it's
elevated.
parallel. Oh,
Yeah.
parallel. Okay, gotcha. Okay.
Hmm?
She said the urethra was expanded when I dropped it in.
Some micturition going on over there.
Mastication, right, Charlie?
Now this might help y'all remember this as well, guys. I was talking about the shape of the kidneys. Just to give you a little bit of a extra way to remember this, we're talking parallel versus perpendicular. Another reason this is considered perpendicular is because that side is touching the IR. But because that's elevated, there's space, or OID, it's gonna place it more parallel. Does that make a little more sense that way?
I
No.
think I would need to like
My s-
physically see it. Like, can you do it with that mannequin? Like, can you just, so I can see?
Can I just do myself?
I can't
RPO.
see kidneys.
Can't see his kidneys either.
Not the bone, the muscular man. Well, is it?
Oh, this one
where you
here?
go, doesn't he have
Like this, so you're touching it, you know, cause you're going like this, it's perpendicular.
Let's pull all
The
these
other one
organs
is
out.
not fully down, so it's gonna be like this, parallel.
There you go, see?
Alright.
You killed it.
See what I do for y'all? Alright. LPO.
Okay.
It's the side down. That's the star of our show, the left kidney. It's down, it's considered perpendicular. This kidney is elevated in the air. That's the right kidney. That one is considered parallel because there's a space between the kidney and the IR. But also, it's going to put it more slightly oblique and lateral in view, while this one's going to be on its side more in profile. But it's a little easier to remember if you think about the side touching because the side is up in the air. Side touching is perpendicular because it's directly touching the cassette. Remember, parallel always has a space.
Yeah.
That's the side up, creating a space between that part and the IR. That's its parallel.
Gotcha.
So RPO, right kidney's perpendicular,
Mhm.
left kidney's parallel. Make a little more sense like that? I'll let y'all witness the damage you did to this poor person right here.
Samantha got you on camera.
You ripped her heart out.
She
Literally.
got you on camera and you clearly did it.
Oh, you may think you saw what you saw, but did you really see what you saw? You know all these camera tricks and special effects these days?
Put John's
Deep
head on
fakes,
Mr. Donahue.
Deep fakes. Can put this back together. All right, moving on. Okay, so what are we looking for? Patient rotated 30 degrees. No superposition of the kidney farthest from the IR on the spine. The entire downside kidney. We want the bladder and the lower ureters as well. And of course, contrast medium filling those kidneys, ureters, and bladder totally. And what's the time interval we usually do these on? What? Really early,
5 to 10.
5 or 6 minutes. 5 or 6 minutes. That's one of the earliest films you do.
That one says 10.
Hmm?
Does that one say 10?
10.
Yeah, the one that's marked.
Oh yeah, look at it. The little clock at the bottom.
Oh, that's pretty good. Yeah. Should be about 5 to 6, 5, 6, 7 minutes. 10 would be too long. You want to do it 10 minutes.
So that's the first exposure?
No, it's not the first. You're gonna do a scout, then usually do like a 5 minute, then that 5 to 6, 7 minute, you're gonna start doing your obliques. All right, so retrograde urograms. This is the next type of procedure we're gonna talk about. These are done primarily in surgery and requires us to catheterize the ureters directly, thus the name retrograde urography. Retrograde urography. Retrograde means what?
Going back.
Reverse
Oh,
flow.
flow.
Reverse flow. Correct. So we will inject contrast directly, well, we won't, the urologist will, inject directly into the pelvic calyceal. That's a tough word to say, pelvic calyceal system. So where do you think that's going into? Pelvic calyceal,
Yeah.
renal pelvis, and renal calyces. So we're catheterizing the ureters, but we're injecting directly into the renal pelvis and filling up those calyces, major and minor. Pelvic calyceal system. It's going to give us an opacification of the renal collecting system, good evaluation of the kidneys and how they're functioning. And that's indicated whenever the collecting system is having renal insufficiency or contrast sensitivity. Oh man, now we killed Jay over here. Everyone's passing out on me today. He doesn't even hear me. He's out cold.
Don't throw that at him.
Oh, don't throw this at him.
Just because.
Do it.
The camera's rolling, I can't throw anything.
Turn off the camera real quick.
Tap him on the back.
Well,
All
it's
right,
there.
so retrograde urograms, once again, classified as a purely operative procedure, although Charo did one that was in a fluoro room, but technically this should be done in surgery by a urologist. And it's going to be carried out, it should be, let's see what they did wrong, Charo? Should be done in aseptic conditions, which it was not. An attending urologist, a nurse, and a radiographer to be present. This is a urology exam. The radiologist is not involved with this. And we're going to perform it in what's called a cystoscopic radiographic exam room. Cystoscopic radiographic exam room. There's specified rooms in surgery that are supposed to perform these exams. Cystoscopic radiographic exam
You
rooms.
just didn't teach some of those people, that's the problem. They should have been your student, and they would have knew that.
Should have been.
Why do they have certain rooms?
Because it's quite the advanced setup.
Oh.
There's specialized equipment for setting that patient up for these exams. These are your, I don't know if I want to say that out loud or not.
Say it.
So when I was at TCH, we called these the spread eagle exams. Because every time you walk in, there's spread eagle right in your face. That's what you're going to be looking at for 2 hours.
It takes
Like,
hours?
face towards the person.
Or at least how they set up at TCH, it was always right there when you walk in.
Like, swing the door open, somebody's walking behind you, and they get a show off the roof.
You know, there's always a show in surgery. They don't care in surgery.
Wait, are they knocked out?
Well, they're knocked out.
Okay.
Yeah, please,
Yeah,
I
but
hope
they're
so.
children.
Yeah.
I seen a man with his angle.
So,
There you go.
spread eagle exam, there you go. That's why we call it the spread eagle. Not a very politically correct term, please don't repeat that. That's what we used to call it at work. So, we're gonna utilize that position all the way back from semester 1, guys. Y'all remember the lithotomy position? This is where the lithotomy position comes into play. There'll be supine, I can't talk anymore. Supine on a cystoscopic table, that's a specialized table, which is why they have the specialized rooms. Knees will be flexed over stirrups, and they have adjustable leg supports to put them in the lithotomy position. Urologists will perform the catheterization, thank goodness. They'll get 2 urine specimens for cultures and microscopic examination, and then they'll begin the actual test for kidney function by injecting the contrast. So what do you think you're doing all this? What's your role?
X-ray.
Right in the C-arm. The
X-ray.
C-arm exam. It should be a C-arm exam. I say should because apparently Charo did one in the fluoro room that should not have done. But this is a C-arm exam.
Yeah, we're a retrograde.
You're still looking at the kidneys? So the radiographer will recheck the position, take a preliminary image. You'll still do the scalp with your C-arm or your mobile X-ray, depending on what they ask for. They'll inject that contrast directly into that renal pelvis via the ureters and proceed with the overall examination. You'll do 3 AP projections. You're going to obtain what's called the preliminary image, which is like your scalp, pilogram, and then your ureterogram. What do you think the pilogram is? Because these also have a name of retrograde pilogram. It's an alternative name. Pilogram is just going to basically be when they fill up the renal pelvis. Renal pelvis, the calyces. That's the pilogram. Ureterogram, what do you think that is? The ureters. The ureters specifically. So they start up near the kidneys, You're gonna go lower towards the ureters, and that's when the exam will conclude. We're not really concerned about the bladder or the urethra for this exam. It's ureters, renal pelvis, and the calyces. And that's what it'll often look like right there, guys. Your prelim. There's your catheters, by the way. See how it goes up the ureters with that U shape? Coming off of this main catheter, you got this little, looks like a little antenna coming up. They'll start directly injecting that contrast. Retrograde action, filling up the kidneys. And they're filling up the pelvis and the calyces. That's the pilogram. And then ureterogram, they're gonna have that full fill of the ureters themselves with nice and fat. You can see right there. Fatten up the ureters. And that's your retrograde ureterogram. Really, it's mostly done by the surgical team. You're just there with your C-arm. Fairly simple.
So preliminary images where the catheter is.
Check the placement. That's like your scalps.
Parallel.
Pilograms when you start filling up the pelvis and the calyces. And ureterograms when you get the full filling of the ureters.
Even though it's going down to up. to fill
Correct.
up the renal pelvis and calyces.
Correct. All right, let's talk about cystograms. What's a cystogram, guys? What's cysto mean?
Kidney to the bladder.
Not kidneys.
The bladder.
We're moving off the kidneys now. It's just bladder. Keyword cysto means bladder. Cystography, so image of the bladder. And it's right there, radiographic examination of the urinary bladder. Usually performed by retrograde contrast administration. So we're going to insert a catheter into our patients and manually inject contrast. Or they're going to hang the contrast on a pole and let it fill up with that retrograde fashion as well. Have y'all seen, which way have you seen at Harris Health? You can do it both ways. Do they manually push it in or do they use the contrast on a pole? On a pole.
I've seen the manual push.
They do it both ways, just depends.
I think I had seen the one, like the lady had a artificial bladder.
Oh, really?
Yeah.
Artificial bladder.
They had to take hers out or something like that.
Interesting. These are, speaking of artificial bladders, that's the reason they do these is for, y'all ever heard of prolapses? Some females have uterine prolapse, they also have bladder prolapses, which, can be, I always think about that because my grandmother had that. She had a bladder prolapse.
Does it like come out?
It starts coming out. Yeah, it starts falling out. Yeah.
The bladder comes out?
Yes.
Like your uterus?
Like out, or you just like feed it coming out?
You know what?
Like, does it completely come out, or
It-
she just
well,
like?
according to my grandmother, it used to come out so far she'd have to push it back in.
Whoa.
So she used to have one of those meshes. Remember that the thing with the meshes way back when? They would hold all that stuff in. They didn't work.
They
So
sued
she
them
actually
though, right?
she actually got a bunch of money
Yeah, they sued
from a
them.
lawsuit on that.
Yeah, for that.
Yeah. Hmm?
Where's the money you got?
I didn't get any of that
Oh,
money. Unfortunately.
No, what was I gonna
If
say?
you or a loved one have been
What is it?
affected by it.
That's how the commercials would sound. But
Yeah,
they
it's
they
the-
actually people cleaned up on that. They got a bunch of money off of that.
Well, it wasn't
All
doing the
right.
job or something?
Hmm?
It wasn't doing.
They were deteriorating.
Oh.
Yeah. Okay, so indications for cystograms. Vesico-ureteral reflux. What's that referred to? Vesico-ureteral reflux. The contrast is going back up the ureters. We don't want that to happen. It's a bad thing. Recurrent lower urinary tract infection. If they have a lot of infections going on downstairs, they're going to have these done. A neurogenic bladder, bladder trauma, lower urinary tract fistulae. Remember what fistulae are? It's those undesired connections to other organs. Urethral stricture. What's that? Narrowed urethra. And posterior urethral valves. Contraindications are going to be related to catheterization of the urethra. If they can't handle the catheterization or the infection's so bad they can't catheterize as well, so on and so forth. Catheterization can actually be very tough on certain patients, especially if there's a stricture present. You never want to force that catheter either. That's one of the few things that makes me squeamish is catheterization. It's I always hated catheterizing patients, just being really squeamish. really, really squeamish. I don't know why, but
Is that in our scope or what?
depending on where you work, yes.
Is that what, something they show you there?
Mm-hmm. They train you how to do it. A TCH
Yeah, I've
they
never
do.
seen a tech do that. I've never-
Depends on the facility. Most, I think most facilities have nursing do it, but where we worked, we were expected to learn how to do that. I did not like doing it. Mhm. Babies and kids. I always feel so bad because it's painful. It's painful getting catheterized. All right, so contrast media, we're going to use the same non-ionic organic compounds that we use for IVUs, non-ionic being the one that's going to cause the least amount of allergies. Typically 30% for our retrograde urograms. Injection equipment, you'll use a sterile catheterization tray. Very important to use a sterile catheterization tray. Why? Because that's the source of the most infections when we're administering catheters. And we recommend that you use a pre-mixed contrast solution and not manually mix that, otherwise your concentration will be wrong. So aside from learning to catheterize, you'll learn how to do these sterile trays. And this is an area where you have to be super efficient with using your sterile gloves and set with that sterile tray, because like the smallest mistake can introduce infection to that bladder and urethra very easily, very, very easily. So that's what it'll look like. Of course, you'll fill up the bladder, then they'll pee it back out. It's usually just on the table. So have lots of towels nearby when you do this. It can also be difficult to get your patients to pee, whether an adult, child, whatever. Obviously being self-conscious, someone's telling you to pee on a table, everyone's watching you. No one's gonna really wanna do that. But as best you can, direct the patient to do so. And I told you all the trick with kids, you pour water on them. Did I tell you all that? You pour warm water on them. I think Ms. Smith said tickle their feet, works too. Also just turning the faucet on, the sound of water can make people want to use the bathroom. All right, so preliminary preparations. Protect your table from urine soilage, unless you want clean pee off the table. Make sure you put lots of towels all around your patients. Accompany them to the lavatory, give them supplies for perennial care. You know what perennial care is? Make sure you're cleaning down there efficiently. Instruct them to empty their bladder all the way. Now you place them on the table for catheterization. After that catheter's in place, position that patient for the preliminary image and the first cystogram. We'll be doing an AP projection, like a little bladder shot. At that point, after the bladder shot, the physician will remove the catheter clamp, drain the bladder, and introduce the contrast material. So any residual urine will be drained out at that point, because even though you tell them to go, some people are still retaining urine. That's probably why they're there in the first place. So he'll drain that urine out, then they'll let that contrast start flowing in, whether by hand injection or the bottle with the little pole. So once again, guys, if you're ever doing catheterization, I keep telling this over and over again because I've just seen this happen too many times. Make sure you catheterize correctly. Males, pretty easy. Females, make sure you catheterize the correct spot, guys. I cannot say that enough, and I've seen males and females do that incorrectly. So please catheterize correctly, or you're going to cause your patient a lot of pain and discomfort and possibly infection. Use extra care. Make sure you clean the spot as well before you catheterize. Please use lubricant before you catheterize. But if you work like at a pediatric facility like I did, you'll be expected to know how to do this, which is why I'm warning y'all.
But like you said, they'll train us.
They'll train you. They'll train you.
But
People
don't
still
ever
screw
go,
up.
But don't ever go in there saying you don't know how to do it, right? Just say, oh, okay, can you show me just to get it?
So make sure you know what you're doing.
Yeah, I'll go in there saying.
I'm just saying, know what you're doing. You don't want to hurt. You don't want to hurt your patient. You don't want to hurt your patient. I've seen it happen.
Sure.
I've seen it happen too much where people get hurt doing this.
Where did she say, what do I do?
All right, our initial images are going to usually be our 4 projections: 1 AP, 2 AP obliques, and 1 lateral. We'll go over these individually.
Well, I don't think they'll ask you that.
No, they're not going to ask you that.
Oh, yeah, oh, okay.
They know most people coming in don't know how to catheterize.
Well, if they do ask, I would be like, yeah, I know how to do it.
259.
Of course.
You should just tell me the truth.
I really thought it was 2:15. I really thought it was 2:15.
That is where I'll end the day, actually, guys, because I'm looking at the next slide.
Great.
That's a good